Ventricular storm, defined as greater than 3 ventricular tachyarrhythmias within a 24-hour period, is undoubtedly a life-threatening condition. When ventricular storm occurs in the post-myocardial infarction setting, it is oftentimes associated with ongoing ischemia, cardiogenic shock, and pre-existing arrhythmogenic substrate. Management of ventricular storm can oftentimes be difficult and may demand a multifaceted approach. With this in mind, we present a novel case of refractory ventricular storm in the post-MI setting with incomplete revascularization. This was successfully treated with a dobutamine infusion. A 64-year-old female presented with a non-ST elevated myocardial infarction. Subsequent angiogram revealed severe 3-vessel coronary artery disease. The patient underwent CABG with a 2-vessel procedure, Lima to LAD, and SVG to left circumflex. However, the RCA was unable to be grafted. Then, on post-op day 7, the patient developed sustained polymorphic VTAC and electrical storm. Trials of metoprolol, amiodarone, and lidocaine infusions were all unsuccessful in resolution of the patient's electrical storm. Ultimately, she required intubation, and she received greater than 25 defibrillations for treatment of her electrical storm. Due to the refractory nature of her polymorphic VTAC, left stellate ganglion block was performed. However, this did not resolve the patient's VT storm. The patient developed worsening hypotension several hours later with R-on-T phenomenon and PVCs. Finally, as a last resort, a dobutamine infusion was started, with subsequent shortening of the RR interval and resolution of her electrical storm. In conclusion, the etiology of electrical storm varies. However, the treatment modalities include beta blockers, amiodarone, lidocaine, and suppression of sympathetic tone with sedation and intubation. In refractory cases, stellate ganglion block has been utilized as a last-ditch treatment to help reduce adrenergic tone. In this case, the patient's VT storm was refractory to all traditional treatment modalities. The patient's ventricular storm was thought to be due to ongoing ischemia and incomplete revascularization, leading to subsequent PVCs and R-on-T phenomenon. While a dobutamine infusion is traditionally thought of as pro-arrhythmogenic, in this case we theorized the dobutamine infusion shortened the refractory period, thereby preventing PVCs and recurrent R-on-T phenomenon. At 6-month follow-up, the patient had improved EF and no further shockable events. Thank you for your time.